Okay, so management of coronary artery disease. As told by the Medical Knowledge Self-Assessment Program as shown in this picture, it's used by residents for their board exams. Okay, so coronary artery disease is broken into risk factors that may be modifiable and non-modifiable, and of those, it is said in this book that cigarette smoking results in 2 to 3-fold increased risk of dying of a cardiovascular disease. On top of all of this, psychosocial stressors that include depression, anger, anxiety, they also play an important role in cardiovascular risk. High sensitivity C-reactive protein is a relatively new marker for coronary artery disease, and the slide basically explains it all. Okay, so the most important thing I think everybody has to know is what the definition of angina is. Please read it. And amni, I'm sorry if I'm saying it wrong or I spelled it wrong, but just look it up because it means impending doom in, I believe, Latin. The pre-test probability of coronary artery disease in symptomatic patients is determined by the age and sex of the patient and a description of the chest pain. So cardiac stress testing is the most useful diagnostically in symptomatic patients with an intermediate pre-test probability of the disease. For all of those who wanted more detail from this book, it says that in recent years, dramatic advances have been made in percutaneous management of CAD. There's newer anticoagulants, drug-eluting stents, vascular closure devices, and in medical therapy, because like statins and beta blockers and ACE inhibitors, there's also several trials that have been done, like the Courage trial or the BARI 2D trial, which all basically compared medical therapy to PCI. In the case of CAD, PCI is going to be reserved for those patients who remain symptomatic despite optimal medical therapy, or if they are unable to tolerate the side effects of those medications, or they're high risk. Okay, acute coronary symptoms, what do they comprise of? Unstable angina, non-ST segment elevation MI, and ST segment elevation MI. These charts should explain that. This is just a slide to show the basic pathogenesis or pathophysiology and the common causes that actually are like atherosclerosis is the most common cause. So TIMI risk score, thrombolysis and myocardial infarction, as this slide has already said, is based on 7 prognostic variables. And this one thing that I wanted to put on the other slide is that according to the risk score, they can be a low risk or a high risk, and if you have a 0 to 1 score, there's a 5% risk by 14 days after the MI that they may undergo death, mortality, or a new recurrent MI, or they have a severe recurrent ischemia that requires urgent revascularization. And that same slide does again mention that if you have a score of 2, 8%, 3, 13%, 4, 20%, 5 is 26%, and 6 to 7 is 41%. This picture is showing the basic management of the first 2 acute coronary syndromes. Okay, so treatment consists of medical and non-medical. The medical is anti-anginal medications, antiplatelets, anticoagulants, and lipid-lowering medications. Okay, so you have beta blockers, aspirin, nitrates, CCBs. It's also said that patients that undergo coronary stent placement following an acute coronary syndrome should take the clopidogrel for at least a full year. Okay, so invasive versus conservative management, the majority of contemporary trials evaluating these two alternatives has shown a benefit for early angiography and revascularization, which is an invasive approach, and the timing of the coronary angiography varies, and there's many trials as to decide those options. ST segment elevation myocardial infarction, this is the more severe version of an acute coronary syndrome. Just real quick on clinical features, because clinical diagnosis is also important and tells really good physical signs there, all the what you're going to hear on your STEP. And conditions that mimic this condition, as well as the high-risk features, these two are specifically from the book. Really quickly, the cardiac markers, creatinine kinase is the most well-known. Everything's given there. Next is cardiac-specific troponins, normally not detectable, and then you have myoglobin, which is excreted really fast. Patient therapy, in this case, PCI is the way to go in most cases. However, if there's any contraindications, then thrombolytic therapy is there. Also, if there is a non-PCI capable facility, then transfer to the primary PCI facility is of choice. However, otherwise thrombolytic therapy is again the option, and the door to needle goal in case of thrombolytic therapy should be less than 30 minutes. These are your thrombolytic agents, and the additional bleeding complications include bruising at the venous puncture sites, hematuria, and GIT bleeding. Just a bit more on the thrombolytic therapy. If there's a continued chest pain, lack of improvement in the ST segment elevation, and hemodynamic instability, and the absence of reperfusion arrhythmias, then it's a likely failure of the thrombolytic therapy, and it indicates the need for rescue PCI. This is just the general guidelines, as I've said before, between PCI and thrombolytic therapy. There is many trials that have been conducted to study what glucose has an effect on post-MI patients, such as the NICE sugar randomized trial. Up to 75% of patients with an ST elevation MI will have some type of arrhythmia during the peri-infarction period, meaning that during the early complications of this ACS, there's going to be some sort of arrhythmia elicited in these patients.